Welcome, guys, to our program today. My name is Anissa Mitchell. I'm with PMD Alliance. Today, we are doing the first part of a three-part series in partnership with our friends from Kiowa Kirin. And today, we're going to be talking about the care partner roadmap, sort of the care on the continuum. And so hopefully we have some of you that have pre-registered care partners that have already received. One of the things that we attached was a handout. It looks like this. It's called the Roadmap to Care. If you didn't get it, don't stress, because we will make sure that you get it after the program. We did try to send that in advance, and we're going to be referencing that today. We're not going to be going through it per se, but we are going to be referencing it. And Kelly did just drop a link in the chat if you want to grab it if you didn't get it. But we created this actually with Kiowa Kirin last year, and we wanted to go back to it because as part of the survey that we did in partnership with them, we went back to some of the verbatims, meaning the comments that people made in the survey beyond just the actual data from clicking a box and responding to something and getting, you know, a percentage of somebody's answer. We actually wanted to hear certain comments from people, and we went through those comments. And some of the key comments that we found were people wanting to know, what do I expect with this disease? How do I plan during this disease, knowing that each individual with Parkinson's and related disorders is going to be unique to themselves, but there's still sort of some things that might be common in terms of treatments and things that you can be doing and things that you can do to help prepare to make life a little simpler for you as you go through the journey. And that's what we wanted to try to capture. And we're actually going to be referencing some of those comments that people made and frame the program around today. So that's why we created this, so that you can kind of use this not only from today, but this is kind of like your roadmap to refer to, you know, later to kind of help you as you're planning. So with me today are two incredible experts. And our first one is Dr. Mindy Bixby. She is a neurologist and movement disorder specialist at Hoag in Newport Beach, California, and Ocean Neurology in Laguna Beach, California. And we're excited. You probably have met Dr. Bixby if you've been on our programs before. And then also joining us today is Amy O'Rourke. She is founder of the Cameron Group Aging Life Services, which is located in Orlando. She has her master's in public health. She has a master's certificate in gerontology from the University of South Carolina. She's also a licensed nursing home administrator, a certified care manager, and the author of the book, The Fragile Years: Proven Strategies for the Care of Aging Loved Ones. And let me just say, I've worked with both of these experts several times, and I couldn't have picked two better people to address this topic. Obviously, Dr. Bixby being an expert in movement disorders with such a compassion and empathy. And Amy, who I've worked with for many, many years, and she's helped a lot of people with Parkinson's, their care partners, the adult children and family members, kind of navigate some of the struggles of, you know, how to be practical and pragmatic in planning, and what to do if you didn't plan and you end up in a crisis, and what are some things that you might need to know. So those are some of the things that we're going to be tackling today. I do want to encourage you to ask questions throughout the conversation today. This is really going to be mostly conversation style. So there's really not going to be slides, but we do want to hear from you. So we're going to intertwine those comments and questions as we go along today. But I want to start off first by the first comment that we framed this program around today from the survey that we did. And that was this comment: I was overwhelmed by reading about this disease online and became quite concerned about the enormous amount of responsibilities that a caregiver must do, as a result of which I made several mistakes in my early days of providing care. So my first question is for Dr. Bixby. What would you say to someone who says they're overwhelmed by what they find out on the internet. What are things that a care partner should know at the beginning of the journey to kind of maybe not go to that place of overwhelm?
Perfect. So thank you. So happy to be here. So ultimately, when I first meet somebody that may have a movement disorder, we evaluate them, making sure that this is their diagnosis. But when I talk to the person that has Parkinson's, I also please ask for the person that's going to be taking care of them or a part of their lives to be there as well. Why is that? Because this journey has to be a family journey. And ultimately, a lot of times you may have misinformation when you only come by yourself. And if the caregiver or care person is there with you, they'll be able to glean the information as well so that we can walk together with this disease. So the idea is that sometimes you're trying to seek information simply because you may have not have gotten as much information from your doctor. And the question is, who are you seeing? Are you seeing a primary care doctor that also manages maybe your blood pressure, your diabetes? Or are you seeing a neurologist that may not specialize in Parkinson's disease? Or are you seeing an MDS, which is a movement disorder specialist? A movement disorder specialist does this every day, all day long. I've been doing this for almost 14 years now. And from that information of taking time and experiencing this, it comes to play where you understand a little bit more about who's sitting in the room with you and what type of information you need going forward. And every visit's going to be different, of course, and everybody that walks in the door is going to be different. Everybody's individualized in this realm in regard to Parkinson's disease, and also your care partner or your husband, your wife, your daughter, your son, your friend. That's going to be a part of your journey as you walk forward. And so if you are not gleaning the information that you need, you're going to start looking. And I think we all do this. I'm like, oh, what's the color of blah, blah, blah. And, in France, you can now go on the Google and figure out everything from that Dr. Google. But Dr. Google is a very important thing to talk about. It may not be your specific situation. And you may be getting information that's false or misleading or ultimately just not the way that you would normally be educated in this disease. So the most important thing I have to say is that please have the right resources available to you. And if you don't, consider seeing a movement disorder specialist at least once a year to know that there are the right roadmap to get to the place where you want to make sure you're successful throughout the disease state. I would highly recommend, which I do with my patients and the people that are with them, not to look at Google if they can, at least for the first couple times that we see each other, because I'm going to do my best to educate them, but I also don't, I want you to not have the wrong information. And so sometimes it can be quite scary because it is daunting. There is a lot of information on the Google. And again, a lot of good information. But if someone absolutely wants to research this disease, I ask them to go to several resources, whether it be Michael J. Fox Foundation, Parkinson Movement Disorder Alliance, a lot of wonderful sites that ultimately are clear, good educational material, because you can Google anything and it could come up with things that you really don't want to know, and it could ultimately be false and be very, very overwhelming. And so what I ask you please to do is if you're going to go on Google, you go to reputable sites so you get the right information so you don't feel so overwhelmed. And sometimes you don't get to see your doctor for 3 months, 4 months, and you're brewing with that information that may be not accurate.
And actually, there was a recent study that indicated that only about 9% of Medicare beneficiaries, is what they were quoting, even saw a movement disorder specialist. And I know that there's a lot of reasons for that. Maybe lack of access or even awareness that there is a specialty for Parkinson's and movement disorders, and how important that is. So can you, just for a second, speak to what can people do if they don't have access, or how can they build a team if there's not necessarily a team around them that can kind of help with this journey of education?
Absolutely. I mean, I guess it depends on individuals and what they have access to. But the nice thing about it is we're all here together right now. This is one way to actually get the information that is accurate and helpful for you. The interdisciplinary team that we have here, and again, in most centers, is that we have a social worker, we have a nurse navigator, we have opportunities to refer you to certain types of therapies, which I always do when I first meet you, physical therapy, occupational therapy, speech therapy, depending on your needs. I also talk about possibly talking to someone where you can have an opportunity to say, hey, we have Parkinson's. What are the next steps that we can take to make sure that we're ready for the next steps, and preventatively get to a place where let's start getting ourselves set up for maybe things that may never happen, but maybe you're doing things right and stopping the process of some things and preventing things by exercising and taking care of yourself. A nutritionist is always really important. We talk about water, because water is very important for your gut and your gut health, which I'm sure we'll talk about a little bit later. But the idea is you want to have your team, your village, and that also comes into social workers and also social special, caregiver classes, and also get classes for Parkinson's patients. And so that gives you so much information because you're sitting in a group of people that are going through the same challenges you may have, and you have an opportunity to talk about it, or even you just don't say anything and you get to glean all that information by just listening. And so that way you can feel supported as well. So there's a lot of different avenues that you can take based on what you can find in regard to whether a virtual platform like we're having now, even the fact that that is pretty daunting of a number of how many people can see a movement disorder specialist in this nation. And so I think that the access has to change, absolutely, and things are changing in that regard. We have some groups that have virtual platforms that they're able to practice and see patients across all state lines, and we can talk about that at some point if we need to. But I do definitely encourage you to see a movement disorder specialist so that you know where you are first on staging and what are the things you're dealing with. And again, the roadmap care will help you kind of decide where you are in regard to the journey that you're on right now, and help you like decide what are the best things for you to do right now and also to plan for the future.
All right, so we're going to show the roadmap here in a second because I really wanted to go kind of the key things people might expect to see and focus on in the early stages. So as we're diving into that, I'm going to have Kelly share screen because we're getting requests to see it anyway. So we're going to put it up on the screen and you guys will be able to look at it. And then we're going to go through some of the things that we might see early stage as far as symptoms and maybe treatment focus. So we'll give her a second to pop that up so we can kind of follow that journey. And it looks like a little roadmap.
Yeah, I love it. I think it's great. I'm really impressed by everyone that put this together because, I mean, not everybody's going to follow the path perfectly, but at least you'll have a nice roadmap is basically what that's for. And so the idea is she's sharing your screen now. Please go ahead.
All right. And if you can scroll down a little bit, you'll see, yeah, it looks like a little roadmap, but that's the next page that actually starts to delve into some of the things that you might see. There we go. Now it's a little more clear. It was a little blurry. So here's some of the descriptions of early stage motor and non-motor symptoms. I don't know if you wanted to kind of briefly touch on some of those.
Oh, of course. And so when somebody comes to see me, they have a neurological complaint, whatever that may be. And a lot of times people send me patients that have some type of movement change, whether it be rest tremor on one side or just not walking the same as they used to, or they seem to be a little bit slower in their movements, or sometimes they just feel stiff on one side. Sometimes they come in and they just have some pain on the right shoulder and everything has been done and nothing has been really truly evaluated, and they have a little posturing of the hand or their big toes going up, and they're like, well, let's see if that's something possibly dystonia, which is stiffness on one side that you can experience with Parkinson's disease. Also, some people can have just freezing or changing of the way your posture is, and those are some motor symptoms that you may experience at the early stages. The non-motor symptoms can be very vast. I have patients that come in and they have 100 things on their list and they say, is this Parkinson's or is this something else? And again, you always want to make sure that you're not like doing a blanket statement and say, oh, this is all Parkinson's. You also want to make sure that you dive in a little bit deeper and making sure that there's not other things that may be happening as well. But the main non-motor symptoms that we usually see are loss of smell or decreased smell, constipation or slowness of your ability to have a bowel movement. Depression and anxiety can happen because when you have a low level of dopamine, sometimes you have a lower level of serotonin and norepinephrine, which is your mood stabilizers. Some people can be acting out their dreams or talking in their sleep for years and years before they ever have any Parkinson's motor symptoms that they can experience. So these are the things that you may see on an early stage of Parkinson's.
And there was a comment sort of question is, you know, because of the early stages, sometimes it's hard to know when they come in with the list of things. Is it PD or is it age related?
Exactly. That's the biggest, most wonderful thing to ask because, yes, it very likely could be that. I mean, some people have sleep dysfunction for a long time, insomnia from other reasons. And we have to dive a little bit deeper into that. That's what we try really hard to do, is that we're not missing out on opportunities to say, hey, maybe your sleep hygiene's not so good. Maybe that's happening. Or maybe you're doing different things, like you're drinking a ton of water because everybody's saying water, 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 like I just said, and you're going to the bathroom constantly. I mean, all these things we can kind of work with and work through, but sometimes it could be something completely different. It could be your urology issue. If you're a male, you can have a benign prostate, a big one, and you have to fix that benign prostate hypertrophy. It just depends, but that's why it's important to have a movement disorder specialist in your pocket if you can, or a neurologist that's really comfortable with movement disorders, so that you can actually tease out the possibilities of it's Parkinson's disease or if it's something else.
And can we scroll down a little bit, Kelly, to some of the treatment things that we might be focusing on at this point in the
Yes,
disease?
absolutely. Mm-hmm. So when again, most important, do you have Parkinson's disease? You want to make sure you have the right diagnosis. I have people that come in, and for instance, yesterday, I've had someone come in and they had 16 tablets of dopamine on board, and they never saw a difference in their symptoms with this medication. And ultimately, after that long of time, they came to see me, and I'm like, well, I mean, if you're not really experienced it, let's slowly taper off the medication again. I'm not asking you to do any of those things. It's an individual case that I want to tell you about with this wonderful patient. And then we did a DAT scan, and he didn't have Parkinson's disease. So the first step is always making sure you have a good person telling you, okay, these are what we see, and how do you evaluate Parkinson's? Well, you give them dopamine back. And if they're walking, or their rest tremor, or their stiffness, or their slowness is getting better robustly by at least 50%, then hey, we're on the right track. So that's the first step. The next step is to evaluate and say, hey, what do you need? Okay, I haven't been exercising ever, and I'm not an exerciser. Well, I gotta get you going, because that's one of the number one things that will slow the progression of disease, is moving your body. And then there's some people that says, well, I have low back pain, or I can't stand up for that long. Well, there's modified exercise programs that everybody can do. We'll find a way for you, I promise. Okay. Interdisciplinary team is what we talked about earlier. You know, you want to make sure you have a team type way walking forward. So we have social workers, we have speech therapists, we have physical therapists, occupational therapists, but there's also an opportunity to have social opportunities to actually hear your voice and say, hey, these are the things that are hard for me. And you may get more information sometimes gleaning from your support groups, which I think are fantastic. And I think everybody needs a friend. Okay. So we also talked about speech and physical therapy to address concerns about ultimately how you're walking. Is there balance issues? Do you want to start moving faster? And they can help you with that. Preferably people that understand Parkinson's, physical therapists and therapists that you're going to be seeing. You really want to have somebody that understands what you're going through, so they can help you walk through it. Some people are just getting balance therapists, which are fantastic, but you also want to make sure they understand Parkinson's so they can help you through it.
We had a question, if you could explain the DAT scan. What is that?
Sure, absolutely.
Everyone get it?
Sure, absolutely. So a DAT scan, what is it? So it's called a dopamine active transport scan, DAT. And what it's looking for, it's looking to see if your receptors are filled of dopamine. So bear with me. There's something called the basal ganglia, which is where dopamine is made. The majority of dopamine is made. And they look like these little commas, if you look on a screen or an image. And those commas are basically filled with receptors. And those receptors, what they are filled with and fed is with dopamine. And so over time, if you're not feeding those receptors, what happens is those receptors are very resilient, but they also, your brain is very, very efficient. And so if those receptors are not fed for a while, they die off because they're not being fed for a long period of time. So what we look for in a DAT scan, a dopamine active transport scan, is you get a dye in the arm. It's a tracer that goes up to the basal ganglia and feeds those receptors that still are there, okay? And so if you have a dopamine deficiency, you actually lose some of that comma shape because those receptors are gone. So for instance, if you have two wonderful commas and everything looks all filled and happy, there's a question mark. Do you really have Parkinson's disease. And again, this is not done on every single patient. It's done when there's a question mark, when you haven't had a robust response to dopamine, or there's an outlier like, you have some action and postural tremor too. Is that what we're seeing? And maybe something else, not Parkinson's. And so that's when dopamine active transport, or that scan, is completed. And so if you are a Parkinson's dopamine deficiency, you can have like maybe the loss of the little tail of the comma that you're normally seeing, or the head's gone a little bit or all the way. And that will give you an idea that you have a dopamine deficiency. It does not diagnose you with Parkinson's disease, but we know that you have dopamine deficiency. Then we go from there to say, oh, is this a Parkinsonism, which is a different look-alike from Parkinson's disease. And again, we go a little bit further into that. Is that why you try medication first? Oh, I feel better, then there's no reason to do a DAT scan, okay? But if you're like, okay, I'm now on my six tablets a day and I see nothing different in me, and my care partner, nothing different in him, he's still having problems with walking, or he's still having stiffness, or still having tremor, what's going on? Then we do a DAT scan to evaluate, to make sure we're on the right track. And some people don't have a robust response to dopamine. And then you have to ask yourself, do you have a Parkinsonism, a look-alike? And that would be having to talk to your doctor about. And then you can walk forward and see, okay, where are we? And what is it? What is the true diagnosis? Does that help? I hope.
Yes. And totally. And now I kind of want to get into like when you're at this phase of the disease, and this is for Amy, and engage her expertise. So in your work with care partners and families, what sort of planning should people be considering at the time of diagnosis? And why should people not wait until later to think about things such as resources and planning what their quality of life might look like for them, how that translates into steps that they might take?
So I like it, and it's really great to be here, and I'm learning so much. Mindy, thank you for all of that. It's fantastic.
Thank you.
I like to work with a framework of starting with a team, and on your team should be a legal lawyer, a financial person, and a care person. And by care person, there's several definitions under that. Obviously, all the medical professionals, movement disorder specialists, a care manager, perhaps. aginglifecare.org is a place a care manager can help navigate. There's patient advocates that also help patients, clients navigate. But having that team set up, and then the framework that I like to work under is, for me, I've seen clients benefit from getting the hard part discussed first. Like, oh my God, how am I going to navigate the system? How am I going to pay for it? Everybody's worried about the finances. So you want to be clear, and I'll throw out these numbers, and I don't want the session to go in the way of finances, but I'm going to throw out this number because it's important. It's in average terms, not California dollars, but average national dollars. It's about $250,000 per person to pay for care. That's a number that in today's dollars. So 250 times 2 is 500,000. Well, not everybody has that at their fingertips. Not everybody has that in the bank. So then you're going to need to understand, where can I tap into public benefits and get that out of the way so that you don't. I like to relieve a lot of underlying anxiety with the long run. Am I going to run out of money before I die? How am I going to handle this? Get that out of the way. And then make sure your legal documents are ready. And then the big thing is, what if something happens to the well person? I want you to be really clear that if something happens to you and you're the non-Parkinson's spouse, then what is your plan if something happens to you? And once you have those basic things kind of outlined and out of the way, then you can start digging into, with less anxiety, what your own care plan is going to be. And I like to say, how you start is how you finish. I've seen people, they start and they don't want to get help for themselves. They feel guilty. They feel bad. They've got lots of emotional reasons why they shouldn't go out one day a week, do things for themselves. But if you don't get that in that rhythm and that habit at the very beginning, and decide as a partnership that this is how we're going to adjust our lifestyle, because it's a lifestyle change. And then look at the things that you're doing currently and look at what you're going to be doing, and you're going to have to give up and change some of the activities that you're doing. And I'll throw out some examples that you could write down or think about. In my own marriage, my husband does a certain set of things and I do a certain set of things. And so if he can't do those things, somebody's going to have to fill in the gap. And so one person can't do both things or may not want to do both things. So what is going to be your plan for laundry, cooking, housekeeping, yard work, big roof care? How are you going to handle that? And know it ahead of time, talk between each other and work it together so that when the time comes, you've already got that already thought out and discussed and you're ready for it. And I want to throw out one other thought, not to overwhelm people, but when you're not well or you're in a medical crisis, you're going to be interacting with lots of systems quickly, in and out of the hospital, in and out of rehab, doctor's office, the emergency room, home care. If you get a basic understanding of your insurance, I'm assuming for a lot of you it's Medicare, a basic understanding of what your insurance covers, and a basic understanding of how these systems work. And wherever you get that information, I'm sure that Anissa and the team will have those outlined so that you're ready. It's easier to learn them ahead of time so that when you get that call from the hospital discharge social worker saying he's got to go today, you already know that's going to happen. You already know where he's going to go. If you understand that you're on a Medicare Advantage plan and you're going to have to work with the preferred providers and you're going to get a little bit less, you're going to have to fight a little bit harder to get the care you need. Not that it's not possible, but that you're going to have an advocate helping you get that. Understand that on the earlier end, so you're not learning it while the crisis is happening.
So important, because we're already under stress in a crisis, right? So it's harder to make decisions when you're, in that stress and the duress. And sometimes if you don't think ahead, the options are not as available too. Isn't that the case?
Yeah. So I just got distracted by a couple comments in the chat box. Mm-hmm. So 250,000 for a lifetime. Yeah. And I'll use Florida dollars because that's all I know. So, $60,000 a year for assisted living, do the math, $120,000 a year for nursing home. And then the other question is, what percent of PD patients end up in assisted living or skilled nursing homes? I'll just give you statistics of overall, if you're over 65 and over 85, it's a very small percentage, believe it or not. 20% of people over 85 or over 65 end up in an institution. So people think, oh my God, that's going to happen to me, but 80% don't. It's a bigger fear than the reality would play out. The problem that people have is when they need assisted living, they don't want to start paying for help. So they don't ask for help and start paying for help when they need it. So then it creates a medical crisis that's really severe, and then they're paying more. And so I like to say that really the biggest reason that people end up institutionalized prematurely is they didn't ask for help when they need pride. They didn't. Pride or ego or fear, or whatever that emotion is that's driving you, didn't get you to ask for help early on.
I have to say something if I could. I have same statistics here in California, about 20%. People try to keep them at home. As we talked about, aging in place is really important as best we can, but what there's tipping points to that, and we can talk about that a little bit later. But I do agree absolutely with you in regard to knowing and getting yourself set up for that, because I have had patients where there's Parkinson's and we're managing it well, but then I look over and I see the care partner and how she or he is so stressed to a place where they're getting sick, their blood pressure and everything is starting to get worse. And then they're like, I can do it. And it's great to have the can-do attitude, absolutely. But there is a tipping point there where both of you are not as healthy as you would like to be moving forward. And there has to be let's make sure we have a plan in place now, just in case we get there, so we don't know what we don't know, so we don't do anything. And I never want that to happen, because unfortunately things go not the right way, is the way you want them to be. And so my whole family, we had a Thanksgiving, and boy, they're like, oh, Mindy, what are you doing? Bringing everybody down. I'm like, no, I need to know what everybody wants. How they want to be taken care of as they get older and as you age, and what are the things that you feel really solid with the sound of mind and heart and abilities right now of what you see yourself in that way, and making sure that we give you the wishes that you want. And that's a conversation that I think is just a loving conversation, not like, oh, you're being so morbid, Mindy. No, I think it's important that we have this conversation because everybody's different. And if you know what people want, then you're going to walk forward and know, okay, I did the right thing. And no matter what it is that we're talking about. And so I think communication's everything. Yeah.
Exactly. And I like to remind people to access whatever support system you have to get emotional clarity. And I like people to think about it, whether it's a counselor, whether it's your yoga instructor, whether it's your priest, whatever it is, get that support so you have emotional clarity. And then you're really investing in your mental and emotional well-being for the long haul.
Most definitely.
And what I hear is, and I'll say it, if you're yelling at your spouse, if you're irritated, if you're slamming doors, if you're, that's a sign that you're not taking care of yourself. So you can see, and you won't last the long haul. Mindy's had this. I've had couples where the well one, they're just in the hospital because they collapsed from the stress.
Yeah.
So there's some questions. So I'm going to use a phrase and then so lawyer, you need a lawyer. You need to know what legal documents give you permission. In Florida, if you're married and you don't have a durable power of attorney, you're no one. You have to have a durable power of attorney. You have to have those legal documents in order to speak for your person on their behalf. An elder lawyer will know about public benefits and will help you get educated as to what you need to do to position yourself to access public benefits when you need it. And it's very possible to do. There's a 5-year look back. This is a whole session in and of itself. But if you learn it ahead of time and you're middle class, like a lot of the world is, and you're going to need them at some point, it's important to know what your financial trajectory is and when you would need to tap into that.
Yep, I agree.
Yeah, and there was a question about what triggers the need to call or when you should call.
A lawyer?
Yeah.
Oh, right away.
Right away.
Right away.
Absolutely. Honestly, I think if you're an adult, you should have some documents. Like, just because somebody turns 18, their parents can't speak for them anymore. If something were to happen, again, it would be wise to have something. But being young, you don't have to even I have all my documents done because I want to know that if for some reason, if something happens, I don't have to worry about it. There's no stress now. I can update them as I need to, but that look back period, I'm good. Like, if something were to happen to myself or my husband, we're good. And there's a peace of mind with that. There was also a question about, the concept of collaborative planning is difficult when someone has cognitive or psychiatric problems. And I don't know if either one of you want to kind of address that briefly before we move on to some of the other.
I'd be happy to. So we do talk about cognitive abilities, and it's called capacity. And so if there's a question in regard to how much capacity someone has financially or medical decision making, we do get a neuropsychological evaluation to evaluate capacity. And I think that's a really important thing and tool to have through a neuropsychologist. And it helps us kind of understand where we're headed and if we do need someone to actually talk on our behalf based on the testing that is done. The other way that's done, which is not really done very much in California at this time, is there's two doctors that have to sign saying that person does not have the capacity to make medical decisions or financial decisions. For me, I've always went, and I have a good neuropsychologist that's fantastic, that I trust, that I tend to refer to for those questions.
Right. And I would say I'm using the language of durable power of attorney, durable power of attorney for financial decisions, and there's medical power of attorney or healthcare surrogate for healthcare decisions, and you need both.
I agree.
Yeah.
So I want to go back to one of the other comments made in the survey, because we've sort of touched on it, and I think it's part of the next aspect of our conversation is this person said, after just 1 year of being a caregiver, I realized that it's very difficult for me to manage things and keeping a hold on my personal life as well as being a caregiver. We've already kind of touched on that. You've talked a little bit about the burden and the strain and them ending up in the hospital. So let's talk a bit about the mid stage. So when we get to the mid stage of the disease, that's when things might start to become a little more difficult. Symptoms might be a little more harder to manage. Can you highlight some of those motor and non-motor symptoms that may be a little more challenging for the care partner, things that might ramp up that stress level a little bit?
Sure, absolutely. Let's first start with motor, and then we'll talk about non-motor. So motor, usually when it comes to medication management, sometimes if you're not right on time and you do it right after your food or before your food, there's things you need to know. Medication doesn't work as well when you take food with it. And so your timing of your medication can start to be a little bit daunting because of the fact maybe you may need it 5 times a day. And again, you need to talk to your movement disorder specialist again. I do my best to not make the frequency too much, just simply because you're living by your pills. And that's hard. And that means that both people are living by their pills, because some people forget or mid-dose, and you know what happens when you forget a dose, whether it be more stiffness, slowness, some walking changes, all kinds of things can fluctuate. And so when it becomes that you have to be on a timer all day long, it gets hard on you. So that could be one of the stressful moments that you may be experiencing. The second thing is some people have motor symptoms that don't completely get better on the mid stage, where you take the medication and you wait, and usually kicks in within 30 minutes and it's not kicking in. And you're like, okay, did I take the medication? What else did I do differently? And I'm not getting completely on. So I may feel a little more walking changes and maybe a little bit instability that may happen. And then you get concerned about falls. So that's a stress. Or you feel like, oh my goodness, did I do something different? I give them did we change our timing and something was different? And we're always racking our brains trying to figure out what was different this day compared to yesterday when it was perfect. And again, we're not perfect. Our days change. You didn't sleep very well. You may have a little bit more protein on your diet, and that may have made an issue in regard to absorption of that medication. Or it can be likely just, we don't know. Question mark, and that can create stress as well. And so those are motor symptoms of the disease. Non-motor symptoms can be similar. Like some people take dopamine replacement and they feel really good, but when it starts to wear off, their mood may change, or they may feel anxious, or they may feel a little bit where their thought processes are not as fast. And so that may be stressful and concerning for, of course, the person that has this disease, but also the person that's watching them. And so that can happen. Or you may notice that there is a change in the way their thought processes are. And it's like, that's something different. He used to always remember, or she used to always remember, the 50 states or whatever, and he doesn't remember those things anymore. Or just the things I've told him, I have to tell him again, or tell her again. And then maybe more acting out in their dreams, like they're jumping out of bed. Oh, I'm concerned they're going to hurt themselves. And so those are some things we absolutely have to address with your doctor so that we can figure out what's going on and manage those medications the best we can, and also make sure that the non-motor symptoms are discussed, because a lot of times when it comes to Parkinson's, everybody they only treat what they see. But sometimes the non-motor symptoms are the things you feel and are happening to you, but you don't see the shake or the stiffness or the changes in walking. You're feeling it. So that's why the discussion has to be made with your doctor. These are the things I'm experiencing. Is there things that I need to know about Parkinson's that may be non-motor that I'm not addressing because I never had this symptom before? That's when that comes into that thought process. Oh, is this really Parkinson's, or is there something else we need to do? Or your gut is not working very well. We talked about that. You got to have people that are on your program or your village, or your doctor should, is that you have a movement disorder doctor, a GI doctor that understands movement disorders, which so constipation or gastroparesis, which is slowness of the gut wall. You have somebody that you can talk to about it. And maybe if we can't treat it through a neurologist, we have somebody that we can send you to that understands this disease and can help you walk through this. Urination and going bathroom more. What's going on? That's another thing. You have to have a urologist that understands Parkinson's, because hey, your bladder is just like the rest of your muscles on your body. It can spasm. open, close, open, close, open, close, which makes you have to run to the bathroom and go to the bathroom all the time. And it may not be if it's a male, a prostate issue, it's actually the medication is wearing off. So you have to go bathroom, 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 bathroom. And so if I change your medications, that can help you. So all these discussions that we have, as you move through this disease, you may be different, and you're going to be different from every single person that has this disease. And these secondary and first and second, and what stage am I on? I try very hard not to go overboard with the fact that, oh, your number's this, and you're in this stage, because every single person is different, but that everything's manageable. We just have to make sure that you have the right people in place to take care of you. Okay.
Awesome. And we had a question. Let me go back up to it. If you could say, because you mentioned, the medications and the protein, do you have a recommended timing between the meals for meds?
I do. And so at the beginning, I usually say 30 minutes before or after your meals. And so let me give you an example, because people do a sandwich sometimes. Again, we're talking about food. Is 30 minutes before your medication, you can eat, or if you take your medication, you have to wait 30 minutes after. And let me explain to you why. We talked a little bit about gastroparesis. Gastro means stomach, paresis means slow. Gastroparesis means slow gut. Okay, so when you take your medication in, and if you eat it with food, what happens is that both the medication and your food are being digested in the same place, called the duodenum. And it's really, really interesting, a signature of carbidopa-levodopa, that it gets metabolized in the same place your food is. And so you have to know what's going to win every time. Your food. So guess what? Your medication goes down into your stool. Okay. And so you don't get that benefit of that medication because you're competing with your food at that point. Again, some people can do carbs, because carbohydrates, which is like, fruits and sometimes some breads and things like that, and they're quick metabolizers, because they have nausea with it. And so they have to have something on board. And that's probably the safest thing. If you needed to have something and you're starving, you can do some carbs. But when it comes to proteins and fats, those metabolize slower. And so you're going to have some interference with your medication being metabolized. And so I tend to, at the beginning, say 30 minutes before or after meals. But sometimes as time goes by, depending on your gut, because it's your own specific gut, you may be a little bit slower, or you may be really constipated. So we have to digest that too. If you're full of stool and then you're trying to put medication down there, it's not going to work as well, because the whole system's off. And so we talk about constipation on a regular basis too, because people can have an immediate off. Now I'm having off and ons when I never had it before. This disease is slow disease. Things don't come out of the blue in one day. So you have to look at what's happening mechanically that may not be working so well in your gut, which is one of my first things I look at when people say, the medication didn't work at all today, and I don't understand why. It's always worked, always. It's impossible that your disease has progressed. It's more that we have to figure out what else is happening. Hope that helps.
Absolutely. So Amy, I'm going to come to you for a second, because a lot of these symptoms that we talked about do require some practical approach to managing them. So what are some things that care partners might consider doing or putting in place at this point? So you talked about, some of the documents and the financial planning, but what are some practical things related to symptoms that you've worked with families to address?
So it was hard for me to think about this, because I've got so much I would want to say in one burst of so if you're talking about the symptoms, I would make sure that people in your world, in your circle of influence, in your friends, your core circle, are aware of what's going on. And if they have anxiety or distress or discomfort, which happens, people get scared around a tremor or a shake or a confusion. People get nervous. They get nervous at hearing the diagnosis, and then they've got a lot of anxiety themselves. And what happens, I've seen, is people just withdraw, and the Parkinson's couple becomes isolated. So you're going to want to work on the isolation potential with your circle of people. And then the symptoms that I've seen people struggle with the most are the impulsivity, the sexual inappropriateness, maybe inappropriateness in communications, or not showing the emotions, the flat affect, and missing that communication in a marriage or in a friendship or in a relationship. So what I've tried to help people do is find ways to get what you're not getting anymore from your partner and get it in other places, so you're not doing what a lot of people start to do, is getting frustrated with the person that they're not able to meet the needs. Did you understand what I said? Didn't you hear what I said? How come you're not crying at this movie? Why did you say that to this woman? Like, they kind of go at each other when you kind of need to get separated, get your own help with where they are, and are your expectations of them realistic? I'm very, very free with encouraging people to go into counseling, therapy, to process what's happening. Medicare covers counseling and sessions with licensed clinical social workers, so you can get that support for free. You have to check your Medicare Advantage plans, but kind of understanding what symptoms cause you the most stress and figuring out a way to cope with whatever that symptom is. I've had clients say to me, I know I'm going to be at the end if I ever have to change. This comes from a lot of men. If I have to help her in the bathroom, like if there's a symptom, if I have to go into the bathroom and I have to help, that's where I'm going to really, well, then you're going to want to, or should, hire somebody to come in and help you with that issue. Or know that this one guy said, once she needs that kind of help, I'm going to have her go live somewhere where she can get the help all the time, because I'm incapable. I will tell you, my husband is incapable. Something like this happens to me, he's not going to want to do that kind of thing. He doesn't have the stomach for it, the experience for it. I'm different than him. So, but I think emotionally, your partnership is used to providing needs that you you're not going to be able to be getting from that coupleship. And where else can you get it?
And that's so important, because it does tie to the stress and all of those things that we have already mentioned. And another practical thing that I think might be a consideration at this stage is if someone is starting to have problems with falls, or they're, challenged with some of their activities of daily living, like that this might be the time where, if you haven't already received therapy, you're seeing your physical, your occupational, your speech therapist, you're evaluating, like Dr. Bixby was talking about aging in place, like evaluating your home setup. Is it actually conducive to live in there? Do you have steps to navigate that? Might be a challenge, could be a fall risk. Are you able to get into your bathroom with adaptive devices? Are those things that we need to consider? There's those practical aspects that, the earlier you address those, then the easier it is to be able to get those taken care of even before you need them. And I know you help people with that, Amy. So any more things that you would like to say in regards to that?
Yeah, it's funny. I just did this talk at a downsize conference in Ohio. And it's amazing to me, and I'll probably have it myself, where people are hanging on to their house for dear life. Like, it's an emotional thing. It's not the house, it's all the memories and the not letting go and the uncertainty. And then I've seen people make the change, shift into a house that's adaptable, easy, can get around, and they're lighter, they feel freer, they're less to take care of. So if you find yourself hanging on for dear life to that house that was built in 1950 and the bathroom doors are so tiny, and you're thinking about, oh, I'm going to hire a renovation specialist and I'm going to widen the doors and I'm going to put in a new shower. And, some of that's very possible in some of the homes. And there's aging in place specialists, I think it's CAPS, that occupational therapists that work with builders that retrofit homes that are wonderful. I would consider that. But if your home is so old and it's so, it's going to be arduous to get it renovated to where you like it or need it to be, you'll have to weigh that out. What stress do you want to take on? I mean, renovation in a marriage where there's nobody sick is a big stressor. So how much renovation do you need to do in your own home? Not just add that as a stressor. So try to be open to your environment being less rather than more, and ease to get around in. I just had a client whose husband has got Parkinson's, and she bit the bullet and got one of those seats that goes right up the stairwell. And she had a kitchen built upstairs so that he could get what he needed on the days that he had trouble getting down the stairs. Her house is big enough to make that pretty easy to do. And she's really happy with it. When he needs to stay upstairs, he stays upstairs. And now she has the freedom to be downstairs on her own.
Great.
So I know we could probably talk about this for a couple of hours. There's so many things that we could talk about. One of the things that I wanted to cover related to one of the comments on the survey, which was providing daily care, managing medications, making financial decisions, healthcare advocating, and navigating the moods of the patient. Those are a lot of realities for people. I wanted to spend just a minute, Dr. Bixby, if you could talk a little bit about the role of rational polypharmacy, because I know that people get a little overwhelmed, I think, with medications and adding new medications. And then as the disease progresses, there's often a need to add to adjunctives that can address things that the carbidopa levodopa in and of itself doesn't. It's kind of not that it quits working, but it's a progressive disease, and just understanding what's going on here. Why is this important?
Absolutely. Thank you for asking that question. Well, I have patients that come see me for a second, third, or fourth opinion, and they say, well, they just want to keep on throwing meds at me. And is that really the best thing that it could possibly do for me? And is it that the medication just doesn't work anymore for me, and that's why I have to keep on taking more and more and more? And the answer is, as time goes by, it is a progressive disease, and you do slowly lose more dopamine inside the brain. And so you have to find a way to manage that so that it's balanced in the brain. And how do you do that? You give dopamine supplementation somehow, some way, getting dopamine the level that you need so that you feel good, whether that to improve your tremor, your stiffness, your slowness. There's a certain tipping point where you go, oh, okay, I feel nice and even. But a lot of times what happens is you have these on-off symptoms where things feel great for 3-4 hours, and then all of a sudden it goes away. And the idea is, a lot of times it is, let's add another half tablet of carbidopa levodopa so it lasts longer. And yes, that's just one medication. But sometimes if you need it and you're not noticing that the bridging is happening, meaning that you're going off on, off on, off on, you're going to need something that's going to allow you to have a nice even flow, the best we possibly can without side effects, which we'll talk about as well. And so building yourself, you may have to add a new medication for 2 reasons. One, either the medication that we're giving you, carbidopa levodopa sometimes, and a lot of times that's what it is in some different formulation, is not working or doing the job that it needs to do to keep you feel nice and even. And so sometimes people add an adjunct, which means a medication that helps that medication along and work better. And then that's going to be 2 medications. And some people may feel like, oh my goodness, this medication is fantastic, but I'm having the wiggly wobblies, I'm having the dyskinesia, but the dose I'm on is perfect, but I can't stand dyskinesia. That's another medication actually fulfill your opportunity to have dopamine. But if you have dyskinesia, you use amantadine or something. So all those, it feels like, okay, now I'm on 3 medications for the same thing I was on 1 medication maybe 3-4 years ago. Okay. And so the idea is rational, means you have to have a reason why you're doing it. And if the risk and benefit is, the benefit is worth the risk of taking more medications. And so polypharmacy is definitely something that we do as a neurology team, because if you're missing out on opportunities to feel awesome and have a better quality of life because you don't want to have another drug on board that may help you tremendously, then we have to have a discussion. These are your risks, but these are maybe your benefits. And that's why some people are on a different formulation of medications than another person that's sitting right next to you that also has Parkinson's. And so understanding why you're taking a medication is one thing that's most important, is you have to feel educated and know why you're putting that in your mouth. And what is it doing for you? And why would you take 2.5 compared to 2 tablets? And why you would make those decisions going forward? And again, everyone on my team, which is me and the family I'm seeing in front of me, we make a decision together on why we would go forward with going a little bit more or trying a different medication. And then we have a consensus. This is what we're trying to look for to help. Okay, it's worth it. And that's what rational polypharmacy is working as a team to make sure you feel good and not feeling like you're having to dip so much and the side effects and everything else, and choosing to move forward in that regard and making sure it's the right answer. That's why you follow up with medication. How's it going? How you doing? And not making it be out there on your own and not be able to feel like you can talk to your doctor. So that's another thing that I think is important as well that we have to address.
This is so important. And as we're getting so close to the end, this is really for both of you to state, but anything that you want to touch on in terms of challenges of care in the late stage. You've already covered some of them, like the gastroparesis and the cognition a little bit of the off. Anything else from a symptom perspective, treatment perspective, and then from you, Amy, like a planning perspective?
Sure. If you don't mind, just a quick overview of what we're looking at right now on the screen. Some people can have on-offs, some people can have complete offs and they don't know why. Addressing that with your doctor and making sure if there's options there for you, I want to make sure you have them. So that's something you need to talk to your doctor. Some people do a Parkinson's diary for a day in the life of you, and it helps us understand how well the medication's working, if you're having offs, if you're having difficult side effects, and then they kind of, okay, I can look at this, because a lot of people that come in to see me, they look awesome when they come to see me, because that's just what we do, and then they're like, she doesn't really look like this. And I want to know really what's happening to you. So that's one, to kind of understand how to manage and see what's going on so I can help you. We talk about mobility and talking about, hey, I guess it's time to have a walking aid. And what does that entail? And what does that look like based on what your environment looks like in your house, and being able to do the things you want to keep on doing. Independence, the best we possibly can is always the goals. Some people have freezing, where they're starting to freeze when they're walking. And so we have to train by going to a physical therapist what you can do to get yourself out of those freezing times. And that can be helpful with physical therapy, and also some medications may help as well. Pain symptoms happen quite a bit with Parkinson's. If you're stiff and you're not relaxing those muscles, everything from massage to figuring out if you need some hot sit baths, but sometimes just medication you can use to actually calm that pain down. Motor fluctuations we talked about. Fatigue can happen. Again, we talked about good sleep hygiene, making sure you're in a good place with that. And also look at, okay, why are you having more dreams? Is there something that you're doing to actually bring to a place where you're actually having more dreams? Maybe you're having a really aggressive movies that you're watching, and you bring them into your dreams and you don't sleep very well, and the next day it's not so good. So the whole idea is looking at that. Cognitive changes as well, dementia, all those other things we tend to evaluate on a regular basis to make sure we get baseline, and then we understand where you are, and then we kind of help you through that moments, both of you. Decreased appetite, yes, you can have that. Is that gastroparesis, where your gut just feels full? Or is it that you just really constipated? And we tend to talk about that based on what you need. We look at nutritional values. We look and see how much calorie count you're having, and making sure we talk about those things as well. Hallucinations is a possibility that can happen, visual, auditory, tactile, that you may be experiencing, and there's a wonderful medication for that if needed, and basically understanding that, why you're having that. Increased dysautonomia, which blood pressure drops, or sometimes your pulse goes a little bit different, or your urination is different. All those things are automatic things that your body does that sometimes can be a little bit off. And so we tend to ask you, are you having more dizziness upon standing, or are you going to the bathroom a lot more, or there's a lot of constipation? Those things have to be addressed in the late stages, but all stages, to make sure that we make sure we take care of you. So there's a quick overview. So
that was very well done in such a short period of time.
Thank you.
I'll just add one thought, and that's to evaluate the number of hours of care is needed. 4 hours a day, 8 hours a day, 10 hours a day. Who's providing that care? And do you have the funds to pay for the care? You can't provide all of it, and evaluating how much you can hire and when is the time to move. And the other is when to introduce hospice. So at the end stage, you're going to be evaluating how much care. I'm not seeing very many spouses be able to provide the care that a late stage Parkinson's needs. So, but those are the two hardest decisions to make at that stage, truly.
Absolutely. So we're just trying to get all our ducks in a row, so we're okay. We're all going to get something. We just want to be prepared this time, and we have so many opportunities now with Parkinson's that you don't with other things you may get. And so it's amazing to be able to know what to go for each step of the way. And this is a great roadmap for that.
Right. Sure. And having this organization behind you, there's not a lot of diagnoses that have this behind them. Alzheimer's doesn't have anything near this. It's like shocking that it's so predominant, and you guys are so progressive. I'm happy for the group that's on this, that has your support, Anissa and Kelly.
I'm very, very grateful to you as well. I mean, I love what I do, and I'm grateful to be able to walk forward with all of you. And there's nothing like having an organization like this to be able to be a part of it. It's pretty amazing.
Well, and obviously we appreciate you. And as we mentioned at the beginning of the program, in case you came in a little late, this is part of a 3-part series that we're doing in partnership with Kiowa Kirin. And we actually are going to be touching on some of the things that you talked about, and Kelly dropped some of the links in there, but these are the dates just so you can mark them. So next week on Wednesday, we're going to go into sort of the emotional things, some of the things that we kind of touched on superficially a little bit today, some of the emotional tools it can take in caregiving, and what that might look like for you. And then we're going to go even deeper. The next one following that is understanding what ambiguous losses in caregiving. Your loved one may still be with you, but that doesn't mean that you're not experiencing losses. And those can be tremendously impactful on your stress level. It's an existential thing that is just as important to deal with as all the practical things that we discussed today. So we hope that you will join us for those 2 programs as well, as we kind of take this down a little bit more and a little bit more as we go. So, and yes, I think there's been a lot of comments, like we could definitely spend more time on each of these areas, especially diving into some of the advanced stuff. Maybe we need to kind of revisit this and even break it down into a 3-part series just on the roadmap, because I think there's just a lot of questions that everybody has regarding each section of that. And, trying to do it in one is a great kind of overview, but to do a comprehensive overview and answer some of those questions that you have that we didn't get to today, I think that we might have to just put this on our agenda for a future program very soon, because I do believe that there's a lot of need for that. So I want to thank our 2 experts today, Dr. Bixby and Amy. You guys have been fabulous, as always.
Amy, you're great. I'm so happy. Now I know you. I'm very happy. And I'm happy to be part of this series too. I would love that. I mean, I'm all about education. If I can teach you something that you can take in your pocket and keep for a rainy day or do now, I would love that. So please keep me posted on if there's something where we put something in place for this. Happy to help. Absolutely.
Yeah. Fantastic. Okay. And I'll just remind you all, like, if you want to save your chat, because we did put the links in there. I dropped information about the CAPS, what that is, and Kelly just put a program link in there from an Aging in Place talk that we just recently did. So grab those links. You can do that either just by copying it, but it's easier if you go over to the 3 little buttons in your chat box next to the smiley face. And if you pop that up, it'll give you the option to save your chat. And it'll save it to your device, and then you can go back to it later, as I hate for you to lose those links if you really would love to be able to grab them. So I'm going to remove the spotlight just so that we can all see each other in our gallery view, because for Dr. Bixby and Amy, they really do deserve the wave of gratitude that we love to give at PMD Alliance. So I'm going to thank you both so much. And join everybody.
Just love
Love
you, all
that.
of you. Take care. Bye.
Thank you. And I want to thank Kieran, because they have given us so much wonderful information to kind of build some of these discussions around. So thanks to them and their wonderful survey. So we will see you all again soon.
Bye. Take care. Bye-bye.